I was charged with talking about the state-of-the-art of immunotherapy for metastatic disease. I will not be talking about adjuvant. Rhoda Mario will be talking about adjuvant, and then we're going to have a little debate in a little while. We'll see how that pans out of neoadjuvant versus adjuvant therapy. But let's go back to the past and go back 10 years. If you go back 10 years, 12 years, melanoma therapy was a complete disaster. I've been in this business, 30 years? And 10, 15 years ago, median survival was 8 months. 5-year survival was less than 10%. It was a disaster. But then came immunotherapy with checkpoint inhibition, and over the span from 2001 to about 2010, nearly a decade, we developed Ipilimumab for metastatic melanoma. Steve Hody published, and Steve O'Day presented the first randomized phase 3 trial in melanoma that actually was a positive trial. Literally, after 40 years of trying, there was a phase 3 trial that was positive, and it's shown on the left-hand side of those images where Ipilimumab with a vaccine or without a vaccine was better than the placebo arm, which was effectively the vaccine alone. And now you began to get the feeling that you could raise that curve. Instead of 5 or 6%, 3, 4, 5-year survival, now it was about 20%. And it worked in second, third line, which is the left-hand curve, or it worked in front line with chemotherapy in the right-hand curve. So we actually began to have some success, small incremental success in metastatic melanoma. And then if you look to ask whether there was really a survival advantage, meaning was there a tail on the curve? Because in all the mouse experiments done in immunotherapy over 30 years, there was always this tail on the curve of survival for the mouse. And the question was, did you see it with people? And these data from Dirk Schadendorf, this has been presented and then published some years ago, show that if you go beyond 3-4 years in a patient who received CTLA-4 blockade with Ipilimumab, and 3-year survival is the green dot, it began to plateau. So you began to see the same, quote, tail on the curve phenomenon in animal models. You saw it in patients, just like you saw it in mice. So again, more information suggesting that, yeah, there was really long-term benefit to giving immunotherapy with checkpoint inhibition. And then came PD-1. And I guess I first learned about PD-1, must have been back in 2004, 2005. And the initial animal experiments were very promising, although interestingly, relatively few animal model tumors responded to PD-1. When they responded, they did very well. The mice didn't have that much toxicity. The knockout PD-1 mice didn't develop that much autoimmune disease, as opposed to the CTLA-4 knockouts, which would be the mouse equivalent of giving the antibody, where they died of lymphocytic myocarditis. But the animals that got the PD-1 knockout, where you knocked out the gene, they did fairly well, and they only developed late, moderate degree autoimmunity. So the implication was it'd probably be better tolerated in people, and it might work better. Well, it did work better. The initial data came from Omid, who published the first Pembrolizumab phase 1 study, which was, and Omid, correct me if I'm wrong, at that time, the biggest phase 1 study ever done, 600 some odd patients in a phase 1 study, which got into the Guinness Book of Records. At any rate, the data were very promising, both for Pembrolizumab and Nivolumab, both PD-1 antibodies from different companies. And you began now to have somewhat better survival at 2 and 3 years. And the initial data did not go beyond 2 or 3 years, but it was looking very good. And the initial phase 1/2 data said, yeah, maybe at 3 years, now you're beginning to see 30, 40%. So now instead of a 20% plateau, maybe you had a 40% plateau. And then came the phase 3 trials. And the phase 3 trials suggested very early on, if you look at the left-hand side, Nivolumab versus chemotherapy, predominantly done in Europe, because in those days, chemotherapy, sad to say, was still the standard of care. That trial was stopped early on at its first interim analysis because it was so obvious that Nivolumab beat chemotherapy in terms of progression-free and overall survival. I mean, those lines separate very quickly. If you look at the equivalent frontline study, this was done mostly in the US, and there Ipilimumab was the standard of care because it was approved back in 2011. So if you look at the blue and the gold curves, those are 2 different schedules of Pembrolizumab, the other PD-1 antibody, versus Ipi. I think it's pretty obvious from across the room that Pembro, no matter how you give it, beats Ipilimumab. So the survival curve's clearly superior in front line, whether it's PD-1 chemo, PD-1 Ipilimumab, and they very quickly led to the approval of both PD-1 antibodies as single agents in patients with previously untreated metastatic melanoma. And then Pembrolizumab those trials have longer-term follow-up, and we have lots of 4 now and even 5-year data. And again, we talked about the tail on the curve. Well, with Pembrolizumab, whether you're looking at the previously treated patients on the left, in the left panel, or the treatment-naive patients, who are the ones that we tend to see in practice, who get PD-1 antibodies, it looks like at 4 years you're getting a nice plateau, and it's in the 40-ish% range. So again, this is PD-1 versus CTLA-4 blockade. Over the long haul, clearly the green curve beats the red curve. So PD-1 antibody Pembrolizumab beats the heck out of Ipilimumab. And you've got that nice tail on the curve. And interestingly, the frontline patients don't do that much better than the second and third line patients. So this is something that even works in second and third line. So very encouraging data. Maybe we began then to speak of the C word, cure. And then a common issue, we talked about nivolumab, pembrolizumab, both approved for metastatic melanoma. If you ask, and docs commonly in the community ask me, well, gee, if I fail one, should I give the other? Or is one better than the other? And the patients are always asking, well, should I get nivolumab or should I get pembrolizumab? You know, one's given every 4 weeks, one's given every 3 weeks. What's better? My personal opinion has always been, and I have always told patients, biologically, these antibodies have virtually identical activity, and clinically they should be identical. And here are some data now published suggesting that if you look at overall survival, or if you look at time to new therapy or death, they're identical. I mean, they're incredibly overlapping. Now, if you look back at the old data and you do the exercise, which, as Omid pointed out, would give a stroke to the statistician, and you overlap the curves of survival, they're identical. So these are the same drug. If you fail Nivo, you don't give Pembro. If you fail Pembro, there's no reason to give nivolumab. You move on to something else. And everyone always asks, including patients, docs, you name it, how long should I be treated with PD-1 blockade for? And my opinion has always been at least a year, but not more than 2 years. The initial trials of PD-1 blockade, which go way back, the initial phase 1 Nivo and Pembro studies, you treated to progression. And in some cases, it began to get ridiculous. You had patients on treatment for 3, 4, 5 years. And these are not cheap drugs. So common sense prevailed, and arbitrarily, in most trials, the total duration was cut to 2 years. And again, I don't show the slides, but if you look at work from Caroline Webere and others, if you're out at 2 years and you stop in stability, partial or complete remission, 80% of the time you're going to stay there 2 years later, implying you're probably going to stay there forever. Most patients with a PR and a CR tend to stay there if you go to a max of 2 years. In reality, I will almost never go less than a year unless someone wants to quit or has toxicity or progresses, and I will never go more than 2 years. If someone continues to regress over time, I will go as long as 2 years. And again, I think if you look at data from several groups, including one at Georgetown, if you get a PET scan at the end of therapy, and it's a cold PET scan, those patients in that blue curve do incredibly well. So that's a tool I will sometimes use. If they have a positive PET scan, I will either try to surgically resect remaining disease or continue therapy out to at least 2 years, because as you can see in the yellow curve, those patients will not do as well. So again, the answer is still open. Could you get away with 6 months or a year? Well, I don't know. If someone has a rapid CR, I'll ask my colleagues what they think. I might stop no more than a year. But again, that's an open question, an important question that I'm always asked by community physicians and patients. Okay, so that's the past. What's the present? To me, the present is the CheckMate 067 trial, which is Ipi versus Nivo versus the combination. And again, this was a trial that was started back in 2014, and the 5-year data are now out, published, and mature, and there's very nice follow-up. And if you look at the data, bottom line for me is I'd rather be on the green curve of survival which is the combination versus Nivo alone in the blue curve or Ipi alone in the gray curve, I don't think there's any question that you will do better, even though this trial was not powered statistically to show a statistically significant difference in survival between the combo versus Nivo. And the reason is, think about it, we're not statisticians, I'm not, but if you have a moderate difference, and that difference is 8%, which ain't trivial if you're a patient, but to the statistician, that's a modest difference. You need a lot of patients to show a statistically significant difference between 44% 5-year survival and 52%. Nonetheless, the curves break apart relatively early at about a year, and they stay apart all the way through 5 years. There's a plateau. Again, it's the tail on the curve, and this time the tail on the curve is at 50%. That's pretty darn good. So I've always been very impressed by these data, although I will be the first to admit these data are accompanied by significant increase in toxicity, some of which is irreversible in patients who go on the combination. Nonetheless, for most patients who are young and or fit and are willing to accept the side effects, I will virtually always go with combination immunotherapy in the front line. And if you look at the graph that I guess Genevieve was hinting at, it shows what's the proportion of patients who are on these 3 treatments that don't require further treatment and stay in remission without the need for further therapy. They could be stable, they could have a partial response or a complete response. And you tell me from across the room, it's pretty obvious in the combo on the left, you do much better than if you get Nivo or Ipi alone. So I think that's an important thing for patients to know, that you have a greater likelihood of not needing any other or further therapy, and you have a greater chance of staying in remission and doing well. Finally, the present data show that we can now treat patients with brain metastases, and we can also get away with less toxicity. So there are more advances coming with combination therapy. If you look at the results of the CheckMate 511 trial, these were published recently by Celeste Labé and our colleagues. This time they flipped the doses of Ipi-Nivo. So instead of 3 of Ipi and 1 of Nivo for the first 4 induction doses, you flip them around and you do 1 of Ipi and 3 of Nivo. And again, we've played around with this in patients who couldn't tolerate some of the toxicity, but this was a formally done randomized phase 2 trial. Phase 2 randomized trial, since the endpoint was toxicity. It was not efficacy. And the follow-up is only a little more than a year. But again, look at the curve from across the room. Pretty obvious to me. If you look at the survival curve, flip dose Ipi-Nivo looks just as good as regular dose Ipi-Nivo. The statisticians will have a stroke and say, oh, the follow-up is only relatively short. You can't make conclusions on long-term survival with 12 to 15 months of follow-up. Okay, fine, I agree with that. But if you look at the endpoint of toxicity, it was a 1/3 reduction. Instead of 50% grade 3-4 major league toxicity, now you're down to 33%. And for the patients, that's a big deal. And I find that most patients can tolerate flip-dose Ipi-Nivo, and in my opinion, the clinical results are going to be just about as good. If the patients have brain mets, again, go back, not even 10 years, 5 years, it was a disaster. Everyone assumed once you had brain mets, game over. You were going to have a median survival. 10 years ago, the median survival for those with brain mets was 4 months. Well, that's not the case. Ironically, it turns out that using combination immunotherapy, this time the full doses, not the flip doses, you do just about as well, amazingly enough, in terms of progression-free and overall survival if you have brain mets than if you don't have brain mets, with the important caveat that you can't be on steroids and you can't be symptomatic. But again, the asymptomatic brain met patients, in my view, are the majority of patients who have stage 4 melanoma who have brain mets. So again, this was a phase 2 study. This has just been relatively recently published. This was Hussein Taubi from MD Anderson, and it was a straight-up study of regular dose Ipi-Nivo followed by Nivo maintenance. And again, 2 cohorts, either asymptomatic, not on steroids, or symptoms and or on more than 10 milligrams a day of prednisone equivalent, usually Decadron. And again, if you look at the waterfall plot, that's a pretty damn good waterfall plot. That suggests if you look in the brain, you have more than a 50% response rate. And those are darn good numbers, very impressive, better than anything I've ever seen in the brain. And if you look at the overall survival, so look at the survival at 1 and 2 years, it's just as good as what you see back on the 067 curve of survival at 1 and 2 years for those with no brain metastases. Because remember, in the 3-arm 067 trial, you could not go on if you had brain mets. So again, this is a new era for brain mets. This is practice changing. Patients who present with asymptomatic brain metastases in my clinic will generally get treated with full-dose ipilimumab, nivolumab for 4 induction doses. And I think that the results, in my view, have been absolutely outstanding. So that's a great survival curve. Then the other question I'm always asked that relates to the present of melanoma management for immunotherapy is, okay, what do you do when they fail PD-1 blockade? Then what do you do? Well, what I do is that then it's time for Ipi-Nivo, and I'll go with full dose or flip dose. And again, this is a relatively informal assessment. This was presented at ASCO this past year. And if you look at the PFS curve on the left or the OS curve on the right, the red curve is, guess what, combination. So you do much better by using combination after failing PD-1. There have been several phase 2 studies. We're looking at about a 45% response rate. And if I can't get a patient on a trial and or they have brain mets after failing PD-1 alone, often in the community, I will put them on Ipi-Nivo without question. And I think that is the best treatment that I know of right now. And again, I have to remind you that these treatments are not without a significant cost, and I don't mean monetary cost. We can talk about that offline. But in terms of toxicity, a tremendous burgeoning field, which Ryan will certainly confirm at his institution, is how do you manage the immune-related adverse events? And they've even got a SPORE application, one of these big grants, to study this. This is a huge area of study and research. And at our institution, we're trying to figure out how to have biomarkers to predict who's going to develop these adverse events. And back in the old days, I used to tell patients, well, you can have side effects anywhere in the body, except the heart. That's the one organ that's spared. And back in 2016, that was shown to be untrue because Doug Johnson published the first cases of inflammatory myocarditis, in some cases leading to death from congestive heart failure. So it is absolutely true that these drugs, checkpoint inhibitors, can impact any organ, any part of the body, anytime. And there's a whole field of endeavor centering around how do you best manage these side effects, something to keep in mind. So what's on the horizon? We talked about the past. We talked about a relatively optimistic present, although my boss is always fond of telling me, oh yeah, melanoma, you guys have taken care of that field. We should move on to pancreatic cancer and others. That's a bunch of crap. That is absolutely not true. Fake news. There are plenty of patients who progress after single-agent PD-1 blockade. The OS is about 50% for Ipi-Nivo. That means 50% of the patients are going to die of melanoma and really need other therapies. So trust me, we haven't cured this disease yet. So very briefly, I'll tell you what's coming up the pike. Ryan already broached this, the COMBI trial, dabrafenib, trametinib, and the Novartis PD-1 antibody spartalizumab. I'm not going to harp on it, but let's just say, look at that waterfall plot. That's an amazing waterfall plot, 80% response rate, and a significant proportion, something like 30% of complete responses. So the response rates with our treatments are so good, you're not going to improve responses very much. It's the CRs and the duration of response that will now become the parameter that we look to improve. And that's the subject of a randomized study of the triplet versus dab-trem. It's going to read out sometime in the next year. We'll find out what happens. My fingers are crossed, but that, I suppose, has the potential to be a new standard of care. But remember, the triplets, including the atezo-vemcobi that Ryan described that I won't show, again, you have to put those against the idea of giving Ipi-Nivo with a 52% 5-year survival. So that's the competition. We've also seen, we haven't talked at all about TVEC or the oncolytic viral therapy. Tony Ribas had a nice paper showing, with a modest number of patients in the range of 20 or 30, again, complete responses by giving PD-1 plus TVEC, the directly injected herpes virus. And again, 60% response rate, high degree of complete responses, but the caveat being these are mostly patients with stage 3C and stage 4 M1A cutaneous and nodal disease. They're going to do well in any case, but that's the subject of another randomized phase 3 study, MasterKey 265, TVEC Pembro versus Pembro alone. It's going to read out this year, like many phase 3 studies in melanoma, and we'll find out the data, I hope, by ESMO. And then the other idea is IL-2. IL-2 was approved in 1998 for metastatic melanoma. Have I used high-dose IL-2 in the last 3 or 4 years? No. Does high-dose IL-2 get much traffic? Not much, unless you're using it with TIL. But the nice thing is there are genetically engineered and pegylated IL-2s. This is the NKTR-214 pegylated IL-2 type molecule. Look at that fantastic response rate. 50-some-odd% response rate with a high degree, 30+% of CRs by giving PD-1 Nivo plus this engineered or this pegylated IL-2. This is now in a phase 3 trial, and our fingers are crossed. This is, again, a different drug completely. It's an IL-2-like molecule, which could be useful in patients who are resistant or not going to respond to PD-1 blockade. And lastly, we're going to hear from Amod about TIL. I'm only going to show one slide. And again, patients who fail Ipi and fail Nivo, who are BRAF wild type, they got nothing. Or if they fail Ipi and Nivo and BRAF-MEK, they got nothing. I mean, we really don't have effective therapies, and that's an area of active investigation. Phase 2 data show a 36 to 38% response rate with good duration of response. I think that this has a decent shot of getting a phase 2 unmet need approval by the FDA. So we'll see, and we're going to hear all the details later from Amod. So conclusions, combo Ipi-Nivo is the standard to beat for optimal survival. Single-agent PD-1s, Pembro or Nivo, are less toxic. They have very good survival and high response rates, but it's not as good as combination. Ipi-Nivo has excellent activity in the brain, which is great for the first time. The flip dose looks just as good as regular dose Ipi-Nivo, but is less toxic. But there's shorter follow-up. And again, the combination Ipi-Nivo can salvage some patients who progress after PD-1 alone. And we have a lot of new frontline phase 3 studies maturing this year and next. And there may be new standards of care coming up. And again, that phase 2 study in the unmet need PD-1, Ipi, Nivo, BRAF-MEK failures may establish what you do if you have failed all those frontline therapies, and that may give us a new standard of care. And I'm not going to spend any time on this. This just shows all the new drugs that are coming up. So lots of optimism in the melanoma field. Thank you for your attention.